Welcome back, everybody. We're here for an all-new Sensible Medicine podcast. I'm joined on my screen with Marty Macri from Johns Hopkins University, John Mandrola, cardiac electrophysiologist from Kentucky, Adam Sifu from the University of Chicago, and Tracy Beth Hogg, who's joining us from here, UCSF. We are going to be talking about two things in today's video. The first, a new paper out now in The Lancet that is a pooled meta-regression of a bunch of old studies that tells us that natural immunity actually turns out to be quite protective. And then the second part, we're going to talk about conflict of interest, pharmaceutical conflict of interest, and other types of conflicts of interest that may be present in biomedicine. So let's kick this off. Marty, I got to start with you on this. You were one of the first people, I think, who was brave enough to go against the establishment and say what doctors have been saying for a few hundred years, which is that if you have an infection and you recover from it, you probably are going to have some protection going forward against reinfection from that infection. So Marty, I wonder if you might talk a little bit about when you first had this thought, how the reaction was, and what was the mainstream opinion, so 2020, 2021?
Well, I'd like to take some credit for coming up with the idea of natural immunity, but in reality, in 430 BC, after the Athenian plague, as I think Tracy and Leslie reminded me of, there was an observation that people that were infected were highly unlikely to get severe disease. And that became originally the idea of protection after you have infection, the idea of immunity. And then, early on, we were very concerned about how do we staff our hospitals. There was a legitimate concern that we could have an onslaught of patients and half of the providers themselves sick or out, and who would take care of them. So early on, it really became an idea of how do we best resource the hospital? If you're young and healthy, your risk at that point appeared so low that we want those people on the front lines. The idea, remember early on that retired doctors were coming back from retirement to staff the ICUs? Like, that was a really bad idea. And then we thought, well, look, if someone's had the infection, they could be in an ideal position to staff the hospital. So that's when it was pretty clear that we should keep an eye on this. And then, of course, the leading argument against something that we don't like in medicine is there's no evidence to support it. Well, that just means it's an unknown. It doesn't mean that it's not true because of the absence of evidence. So early on, we said, are we seeing people who have been infected with COVID coming in the ICU, getting intubated? Overwhelmingly, every ICU doctor said, no, I don't see that. So if that's the observational experience, we were trying to share that to make it a practical policy, but people were saying there's no randomized controlled trial to tell us that natural immunity is effective. And then we got more and more data, and then the data finally caught up, and then it was obvious that people needed some credit for natural immunity. And so then began the COVID games, really. People deeply entrenched in their position and tribalism and the politicalization of the immune system, where somehow antibodies were Democrats and B and T cells were...
natural antibodies were Democrats, but no, vaccine antibodies were Democrats and natural antibodies were Republicans. That's
So yeah, the politicalization of the immune system.
So that's well put, Marty. And I think maybe if listeners have forgotten, I think in early 2020, it was actually discussed that people who had natural immunity could return to the hospital. I think your point about what is the evidence sufficient to believe in natural immunity, I think this is a mistake people make because randomized trials are very good for an intervention. It's a very different question here. The question is, through no fault of their own, some people happen to get COVID. How do we judge if they have protection from that, experience that we didn't wish upon them, but they just happen to have happened? And the answer is really well-done cohort studies can demonstrate that, and they did demonstrate that. It was known even in 2020. Adam, I wonder if you might say your thoughts on this Lancet paper, your thoughts on this topic, and when you became a believer that having COVID might protect you against COVID again.
I don't want to say something which will get people to just turn off, but I think this is so uninteresting because when we think about evidence-based medicine, it kind of gets to what Marty says, the truth is, right, we take what we know, we take what our experience is, and we take the best available literature, right? And come on, we get immune to things. That's why the human race has persisted, right? And
Right.
like, what would have to happen that there was this new coronavirus that we did not gain immunity to? It just makes no sense. And the likelihood that that was going to happen, was like non-existent. And I do think the point is it's that there was this strange politicalization of this. And as Marty recalls, I was trying to actually find it on the internet before this, because I remember those early days where, okay, you can come back to the hospital, you don't have to mask after being infected, right? And then that disappeared as a possibility. So I think that we should think about evidence-based medicine the way we learned it. Ideally, everything lines up and you have terrific data, you have terrific scientific rationale, and you have clinical experience. Often you don't have this. And this is a perfect example where our historical medical experience and our knowledge of biochemistry or pathophysiology lined up perfectly. And did we need evidence? I don't know, not really. And I'm glad it's lined up, and people are acknowledging it 3 years later, but not.
The irony was the nurse could have circulating antibodies that neutralized the COVID virus, but they were antibodies that the government did not recognize.
Right. And then they're fired as a result. But you know what? I guess I want to draw a distinction. So one of the reasons why the people, I mean, let's be clear, I think they did lie, and I think they knowingly lied because it was obvious, as Adam points out, not uninteresting. To me, the interesting part is the lie. Now, they lied and said it confers basically no immunity, and the reason they kept articulating was, we don't want to send the message, this is to you, John, we don't want to send the message that you should go out there and get COVID so you have the immunity, because we'd rather, if you've never had COVID, get the vaccine. Well, that's a very bizarre take-home point. I wouldn't necessarily conclude that that's what people would walk away with. There are other takeaway points that they didn't talk as much about, which is if you happen to have COVID and you recovered, maybe we don't need to vaccinate you as aggressively. Maybe we can put you in the back of the line. Maybe we should do a separate randomized trial for you. And maybe if you're a 20-year-old boy and you've had COVID, maybe we should let you go and no longer boost you and give you the risk of myocarditis. So my question to you, John, is why did they seize upon that pessimistic idea that it's going to make all these people go get COVID and not the more optimistic, like we can actually deliver our medical products in a better way?
Yeah, I have to be careful because I'm not an immunologist, but I mean, obviously, like Marty and Adam have already said, this is just known. So I'm like you. I'm interested in the meta point of why, what was going on with the messaging, and I'm just struck by the fact that what happened with this pandemic that we couldn't tailor therapy. I mean, we tailor therapy for everything in medicine, right? We look at stroke risk we based anticoagulation therapy based on stroke risk. We base statin therapy on absolute risk. But why couldn't we do this with the infection? And I have some theories, but I think this is one of the biggest learning points from the pandemic.
I guess your point is that sometimes in your clinic, you'll give a statin to an 85-year-old woman, but you won't give it to a 25-year-old man. And
Correct.
right, okay, so that's obvious to me. Similarly, I would think that you might have different vaccination strategies if somebody's had COVID twice, or as somebody I was just talking to, he had it 3 times. Maybe they'll have a different vaccination strategy, but why did it have to be one size fits all? I have a theory. But
let me just say that one of the mistakes I think that was made was treating the American people like they were idiots and couldn't handle nuance. And I take care of all kinds of patients in my clinic, and I can tell you that people can handle nuance if it's communicated appropriately. And I think having this one size fits all thing was just a shredder of trust.
Tracy, why don't we turn to you? What are your thoughts on this?
I want to talk a little bit about the timeline of what I remember too with natural immunity, because it was truly before the vaccine was rolled out. There was so much hope and optimism about people not getting reinfected and not getting severe disease, just like with other viruses, that there was immunity. And as soon as the vaccine rolled out, I do remember that there was a trial looking at antibody levels after getting a dose of vaccine in people who had already been infected, where it showed a boost in antibodies up to the level of 2 vaccines. And so I actually remember, I think some decisions were made based on that antibody article. And I think that what the issue was that we didn't actually know clinically, but it didn't come that much later that we figured out. It was January of 2021 that we figured out that immunity of previous infection against repeat infection and against severe disease was around 90%. And you can actually look at the articles from January of 2021. I'm thinking of one from Sweden, but there are actually multiple. And
but you want to draw a distinction between protection against reinfection and protection against severe disease, because one is higher than the other.
Right. So there's higher protection against severe disease and lower protection. It was closer to 80% against reinfection, but this was only initially. Like, we didn't have the long-term data. And so they both decrease over time, although protection against severe disease decreases more slowly over time. But I think that, what happened was we put out, initial guidelines, and first we were vaccinating healthcare workers and then, older at risk people. But then, then we never really changed the guidelines to say, if you've already been infected, maybe the vaccination policy should be different for you, especially if you're younger and lower risk. And so the question is, why didn't we do that as the evidence changed? So,
Adam, you wanted to say something?
I just wanted to push, I don't know if it's push back, but restate, I think your original point was very good. And I think John's point about that, one of the problems here is that we didn't trust people to make rational decisions. And the idea that maybe, people are going to run out and get infected, so they have COVID immunity, that's irrational, right? There was a time, though, right, early on, when we were very worried about, infection and overwhelming hospitals and so on and so forth. It was clearly safer, right, to get a vaccine than to get infected. And you're better off getting infected after the vaccine. You're better off getting infected after your infection. And what John said is really the point, is that if this was communicated clearly and those steps were communicated, I think not only would we have been in better shape with getting vaccines to who we needed to get the vaccines to, but we'd probably be in a better place now as far as people trusting authorities and saying, hey, you guys took us through a really bad situation in a rational way, which we couldn't manage perfectly because it's a disease that we have no control of.
I couldn't say it better myself. And to me, that's the root of why people don't trust the system. I want to go to Marty about firing, but I just want to make one more point about what Tracy was saying. To me, the place for the randomized trial is what she's getting at, which is that if you've had COVID and recovered, if I give you a dose of vaccine, your antibodies will go up. And if you wait a while and give another dose, the antibodies will go up and they'll go up and they'll go up. But antibodies is not a clinical endpoint. It's a surrogate endpoint. And actually, every antibody situation has a different surrogate correlation coefficient. So even relying on the initial antibodies, which do have a sort of a good R squared, a good correlation coefficient with protection against severe disease, that correlation may not apply to the fourth dose, the third dose, et cetera, et cetera. And so what we needed was randomized trials paid for by two people who got 100 billion reasons why they could fund it, and they could run randomized studies of every booster in people who've never had COVID, people who've had COVID, people who have COVID twice. Marty, let's talk about firing. Nurses were fired, Marty. They wrote to you. They talked to you. They were fired because they got COVID on the job, and then they didn't want to get the vaccine, so they were fired. What do you think?
There was a hospital in Washington State where the nurses were fired for not having the vaccine, even though they had circulating antibodies that neutralized the COVID virus from natural immunity. And then the hospital got hit with a big inflow of patients with COVID, and they didn't have enough nurses. Nurses were calling sick with COVID. The hospital sent a memo to the nurses at home and said, even though you're sick with symptoms of COVID, we need you as a nurse to come in and work because we don't have enough nurses, and just try to avoid the immunosuppressed patients while you're working. And there was a memo to the management saying, try to assign the COVID positive nurses that are coming into work to the COVID patients. But real quick on what. But
wait, just to reinforce that point, what you're saying is that they'd rather have someone who's been vaccinated and actively coughing up COVID than have somebody who has natural immunity. And that's so deranged to take that view.
It's deranged, but it appeases the vaccine gods.
Well, let's talk about that. What is it?
This is a cult. Let's be honest. This is not even scientific. It's not a scientific discussion for a lot of the interactions with the medical establishment. It was an all or nothing indiscriminate vaccine policy because that was a simple message. And if you don't believe me, let me quote to you the ACIP CDC committee when they ruled, they made their deliberation on the booster for 5 through 11-year-olds. This is exactly what they said. Dr. Beth Bell of the University of Washington on the committee said, quote unquote, what we really need to do is be as consistent and clear and simple as possible, pointing out the need for a quote unquote consistent recommendation that is simple.
Rather than accurate, simple.
Rather than scientifically valid. The guy from the American Academy of Pediatrics, are you familiar with that organization?
I heard they made some.
Some people still pay membership dues for it. But the guy, David Chamberlain, said at that meeting, Americans are yearning and crying out for a simpler way to look at this pandemic. And then on and on, Oliver Brooks say, we can't say should, we have to say must, because if we say should, not as many people will get it.
Wow.
I mean, this is a long history of medical paternalism.
But Marty, the cult, I mean, you talk about one element in this sort of religious group, but they have a few defining elements. Here's what I put in their defining elements. Number one, they have a worship of masking. More masking, better, and indefinite masking, good. They like masking down to 2-year-olds. They like a little bit of booster, a lot of it is good. And they have a Joe Biden bumper sticker. And so to me, I mean, I'm a little tongue-in-cheek, but it's a coalition of people who have similar COVID policy views and strong allegiance to the leftmost wing of the Democratic Party. And they're also well represented in the academics and in these committees. And it's dangerous, I think. John?
So they would have a 12-year-old girl get 65 COVID mRNA vaccines in her average lifespan.
You mean the yearly one for the... Yeah. Well, it's the 65th one that gives you that real oomph. That's the one you really need. John, you're shaking your head when Marty says simple, simple, simple. You tell me when we write articles, make it simple. Make it simple. So you do believe in simplicity, but you have limits.
Yeah, of course. But the thing that I thought about when Marty was speaking about these just crazy things is that you can recommend 9 things that make sense, but if you recommend one that's like nuts, you lose your credibility. So the moment you're putting masks on toddlers who, don't want to wear them or take them off during their nap time. I picked up my grandkids and I seen them laying next to each other without their mask, as if COVID doesn't float around the room. SARS-CoV-2 doesn't float around the room. So, this gets to my point about Americans aren't stupid. They can see that if you're doing that, if you're firing nurses but telling them to come in when they're sick, that's it. You've lost it. And if you're a doctor and you do that, you've lost it. And so this is my point. Now, maybe, we were talking last week about maybe in Denmark, things were more common sense. Maybe that's why people trust the government. I don't know. But we have to do better at communicating these uncertainties and nuances.
John, that's so well articulated. That's the thing that really frustrates me about this debate where FDA commissioners saying, oh, it's Joe Rogan's the problem. They're the problem. That's not the problem. The problem is you, under the auspices of public health, you made errors that even someone with just a grade school education can see are internally contradictory, and yet you want them to blindly pledge allegiance to you. Of course, they're going to push back. Tracy, closing thoughts on this topic.
Definitely. I think there's many problems with not giving people the nuance that they need. And it did end up in people losing their jobs. In Europe, they made it clear that there were different, there were different rules for, immunity from infection counted, for the COVID pass that they had. And they made it clear that there was infection-based immunity. And here, I think, the one size fits all policy, it resulted in people unnecessarily losing their jobs, which was very unfortunate. And so I
let me push back. Do you think, maybe I'll put my hat on for if I was one of these people who made this mistake. They'd say that, well, if we had taken your tactic, like all of your tactic, and said, hey, listen, if you had COVID and recovered from COVID-19, maybe you don't need exactly the same vaccine schedule. Maybe we should do some special trials. If we took your tactic, there'd be a lot of people, one, lying about it. They said they had COVID, they never had COVID, or I had a sniffle, I thought I had COVID, or seeking COVID. I guess the second one we already think is deranged, but would people lie about it, Tracy?
Yeah, I mean, I guess, in Europe, they required some proof of a positive test. But then, I mean, we need to get also back to the point that, why did we require these passports and the immunity proof and the proof of vaccination to begin with?
Right.
And I think maybe we're going to learn a lesson from that, we actually didn't have enough evidence to say that these vaccines or prior immunity, was going to keep anyone from getting infected in the future or infecting someone else in the future. And so I think one of the lessons of this pandemic is going to be, that we needed better data before we're like requiring people to be vaccinated or show proof of prior infection.
To go to their kids' school.
To go to their school, to keep their job, to travel to, the last chance you're going to get to travel to see family members, right. And suddenly you can't go because you haven't had a vaccine.
But Tracy, let me pile on that point with something, because people say we didn't know about escape mutants. I think they're really damned on this argument. I always opposed passports the whole time, because in the beginning, if I got vaccinated or my grandmother got vaccinated, her protection was so great against severe disease that the additional benefit of forcing other people around her to get vaccinated was entirely questionable, unproven, and probably very small. To the point where some people have modeled, and now there's been a peer-reviewed publication saying it's in the thousands, 5,000, 7,000 people have to be excluded to prevent one transmission under those circumstances. And then the moment you have escape variants, there's a different problem, which is no matter how many people you vaccinate, she's still at risk of getting it. So either situation, you're screwed. And so you never had a justification. Okay, we're going to go to the conflict topic, but Adam, closing thoughts on this issue. The man who was uninterested.
I said it was boring to begin with. I never want to talk about this again.
And we lived up to that. That's we got to admit, you got to be honest. All right. Now the next part, and we have 20 minutes to talk about this conflict of interest. I brought up
we're on a time limit here. Is this like, JAMA where you cannot exceed 2,000 characters or something?
Well, maybe that'll be a topic of discussion, because Marty, I'm a believer in unlimited podcasting. I like them 2 hours or 3 hours. Now, Adam and John, they are hardworking people, and they're like 40 minutes, and this has got to be, the audience is going to go away. And so, it's a little debate, but it's a Sunday. Let's wrap it.
Yeah, sure, it's Sunday. Tracy's got to go prepare her testimony before Congress about
congratulations.
California trying to gang.
Oh, that's another good point, which is that if that law would prevent people from telling the truth, like in this situation. Okay.
That's right. He hasn't appealed yet, so we still have the preliminary injunction. It's going well. No appeal from Newsom.
Well, that law is going to be struck down by the Supreme Court. There's no chance in hell they'll ever survive. And the biggest mistake they'll ever make is if they actually go after a doctor who can hold their own in debate, because they're going to be humiliated. Okay, anyway. Conflict of interest.
Supreme Court would strike.
Even North Korea wouldn't put up with it. It is so unjust. Okay, conflict of interest. So I was bothered recently because I was asked to stop by GU ASCO, which is the Oncology Clinical Conference. And I got to say, in my field of oncology, I don't know what it's like in cardiology, but it's just so pervasive. Financial conflict of interest. And it's two buckets. There's research, which I think is acceptable. That's a lesser of two evils. And then there's personal payments to doctors. And the personal payments to doctors are like dominates. And all of these young people, this was the point I was going to break to Adam. When I was young, and you were in when I was 10 years ago, 15 years ago when we met, my hope was that with a new generation, we would think differently about conflict of interest. People would take more seriously the pharmaceutical industry's role in manipulating study results, manipulating how we talk about products, and that the younger generation will come in and they'll be reformers, and they will say, you know what, I'm going to personally avoid these kinds of conflicts. I'm going to try to be more independent. And for me, the bitter disappointment of 15 years has been they're just the same as the older generation, and I feel like we're losing this issue. So I guess that was the starting point, and I'm curious what your thoughts are.
I mean, I'll start. And I would say, I think things have gotten worse. The debates in the past was, boy, does a drug detailer giving you pens or pads or a coffee cup make a difference, right? And if only we could go back to that time, right? Now, the randomized controlled trials in, the most respected journals are, funded, written, analyzed, by the companies who are making the drugs. And I think the heart and everybody who gives any talk, right, has a slide with 27 conflicts of interest. And then the difficulty, which is, I think, the most important thing, is that people are intellectually so conflicted that because of what research they've done, because of how they practice, people are unwilling to sort of check themselves and say, this is what I believe, and I'm looking at all the evidence, with those glasses on. So I have trouble analyzing it and coming out against occasionally what I should believe.
They don't even know they're wearing rose-tinted glasses. John, right. You are nodding. What are your thoughts in cardiology, EP?
Yeah, it's so there's two forces going on. One force is that in my field of electrophysiology, we've had this amazing explosion of technology that have really helped patients and helped everybody. So we cannot do our jobs without technology and without collaboration from industry, and we need that. But so the problem, the other force that's pushing against that is that it only works when there's a confluence of interest, and the industry I don't look at them as nefarious. I don't look at them as bad. I look at them as profit. They're in this business to make profit, and they see us as physicians as means for that. And so much of success in academia, success in even private practice. If you want to be successful in private practice and move up that ladder, you have to partner with industry. And so there's just these forces that cause us to need to be friendly with industry. And then, of course, the moment we're friendly with industry, we just lose our ability to have that critical appraisal. And it's Adam is right. It is worse than it's ever been. And I don't know the solution. I feel blessed that, I'm in the end of my career, or in the seventh inning of my career, and I don't need it. But I can see the problem with young people trying to move up both in private practice and academics.
Third inning tops, John. Third inning tops.
You guys promised me you'd talk about baseball, so I guess this is what I have to accept as the.
That's all you're ever going to get. Okay, let me make it a little more complicated. And I have an answer to my own question, but I'm curious how you all think about it. The COVID-19 pandemic, I think, introduced the epithet that people are being paid off. Great Barrington Declaration was part of the some libertarian think tank. That's the allegation. John Ioannidis took $5,000 from JetBlue. Actually, it was like the former CEO donated to a pool of research funds for which some of the money was used for Santa Clara. And then also, many commenters are now the New York Times columnist, because the computer science professor who was the first to advocate for masking, now columnist for the Times. Every time you write a column for the Times, maybe they'll send you some money. People who are columnists for The Atlantic. People who are CNN contributors. They pay you to go on CNN. I wouldn't know. They don't invite me, but I wouldn't also. I don't like cable TV. Then there are people who've created Substacks. There are people who do YouTube. There are people who write books. Are these also not conflicts? Are they different? How is it different than Celgene? Marty, you want to tackle it? How do you think about this space? And also, there's a guy who worked at Harvard who works for the testing. He's the chief medical officer of the testing company. And guess what he says on Twitter every day? You need to be tested. I was like, Jesus, of course you think I need to be tested. So how do you think about these, Marty?
I spoke at an oncology conference yesterday, and I actually met the guy who used to work at Moderna. He left, and he told me his primary job at Moderna was to follow me and see what I was saying and what was critical of Moderna. That was his primary job.
He was hired to keep track of what you were saying about Moderna. I believe it. Yeah.
Now, you're right. Everyone is conflicted with some, right? We have a job, we're employed by the university. The universities receive money. Every single university gets pharma money practically, right? Every single medical center. The problem is when you have a randomized trial or results of a trial, and they are being broadcast by the people who are conflicted, and you don't know that. And that's what we saw when every person went on the news and said, the babies have to take the Pfizer vaccine, right? Everyone was conflicted. Here's an example. So pregnant women were excluded from the original COVID vaccine trials. So to answer the question, should pregnant women get the vaccine, Pfizer launched a big randomized controlled trial in February of 2021. They mysteriously stopped the trial after 349 women enrolled in the study. There was no explanation given. The investigators never said anything. They should say something, right? They have a moral duty to speak up. Here we are 18 months later, the results of those 349 women have never been made public. And it didn't really matter for the American College of Obstetrics and Gynecology and the CDC. They just recommended it for pregnant women with zero data. And maybe that's why they stopped the study. Maybe they realized, hey, we don't need to convince anyone. The cult has converted the leadership of these specialty organizations and the CDC. We don't need to provide any data. And running a study runs the risk of showing that there may not be a benefit in pregnant women.
Yeah, Vinay, I want to just say something about putting negative studies or non-significant studies or in a file drawer, because the whole SGLT2 inhibitor space may not have existed had they not had Elliot Spitzer not sued for open data, so that they could publish the results of rosiglitazone. And then when they found out that rosiglitazone was actually could cause cardiac problems, the authorities said, well, we need to study every diabetic drug for cardiovascular safety. And Steve Nissen showed that rosiglitazone was actually harmful from a cardiac standpoint, or possibly harmful from a cardiac standpoint. FDA said, well, now you got to study these drugs. And so when the SGLT2 inhibitors came about, they found that they were actually beneficial, but they might not have even studied those and discovered that. So
no, that's a good point.
You put studies in the file drawer, that's a bad thing.
Just to further explain this to the listener, what John is saying is that in response to the Avandia scandal, the FDA added a requirement for all cardiovascular drugs to achieve non-inferiority upper bound margin 1.2. You had to show your drug didn't cause heart attacks. That was a condition of post-marketing authorization. That, ironically, allowed them to see the benefit of these new classes of drugs, which allowed them to develop it further. So in a weird way, sort of a safety requirement actually expanded market share in a tremendous way. It's actually
But it wouldn't have happened. It wouldn't have happened if those studies that the company didn't like were stuck in the file drawer.
Sure.
Okay. The so-called publication bias.
So I think there's a lot of themes that we all agree on, but I want to go to Adam's point. Is there a distinction between you and I wrote Ending Medical Reversal? Are we not the same as taking money from Celgene? Or is there a distinction there? And what is that distinction?
No, I think there's a lot of complexity to this because, we know our audience, right? And if we preach to our audience, right, we are going to get more attention from our audience. Okay. Now don't shake your head, John.
Yeah, this is where I'm going to pick. We'll come back to it. All right. We'll allow you your gambit. Yes, go on.
Now, but we have to say, look, we are being true to what we believe. Okay. And we are speaking of that. And if we get attention for that, if we get money for that, that's fine. Okay. But that person needs to be honorable. I'm sitting here with you four people who I all respect. Okay. But I am sure that each of you have thought about other people, on Twitter, on YouTube, who are like, oh my God, that guy's just saying that to get the clicks and get the cash. That's a really difficult area.
Okay, I want to try a stab at this because I think this is a very interesting point. Because I think all of us who've used Twitter, we're like, that person can't be that dumb. They must be saying it, for the likes, right? the distinctions I draw are a few, and let's see if you buy them. Maybe you don't buy them. The pharmaceutical company, they can only make money in one way, by selling a product. The same with the device company, and they only make money from selling it. They don't make money from not selling it. And so the moment that tie is connected, you're tied to something that has like a unidirectional profit incentive. In contrast, I think people can write books for or against saturated fat. I think people have been accused of like, you wrote a book on saturated fat, that's why you promote saturated fat, or you wrote a book not to eat saturated fat. You could write it in both directions. It doesn't have that unidirectionality to it. And then the other thing is pharmaceutical conflict has been shown in like 200 studies. There's like a net vector of bias. These kinds of things, and what you're talking about, I think, is audience capture. The idea that you increasingly get captured by your audience and you stake out a position beyond what you truly believe. And your antidote for audience capture is integrity, which I agree with you. You need to always stay true to your own message to prevent audience capture. I'm curious what John's point is, but the point I would say about my experience on all these platforms is that, like when you use YouTube, definitely the algorithm has its play. Twitter, unfortunately, is not monetizable, so, they can take that out for a second. But YouTube, I think the thing I come back to is that at the end of the day, if you were really in it just for maximum revenue, you wouldn't even talk about medicine at all. You would just go into lifestyle and naked politics and finance, because like the audience for those is like 10x larger. And so to me, that's also sort of an intrinsic check. And then to me, the most scary thought, Adam, is that some of these people, they genuinely believe the crazy shit they say. They really do believe it. They really do believe it, that they drink a bottle of water at work and hold their breath with an N95, and they only use a toilet where you can put the lid down when you flush because of aerosolized I think they believe it. John, your thoughts on this?
Yeah, I couldn't disagree with Adam more about this because look, for the last 10 years, I've been in this space where I look at medical professional societies. They are conflicted because they're supported by pharmaceutical companies. So they're biased in what they can say. I look at journals. What's the model for a journal? It's advertising. It's reprints. And advertising. What's the model for medical journalism? It's advertising. And so they're completely biased. When you take an independent Substack or an independent YouTube, and it's supported by people paying their own money, it's like old-fashioned Hayekian economics. It's just it's fair. It's like buying shoes. If the shoes are worth the price, you exchange money for the shoes. And it's the same thing with Substack and books. And I think that the difference is it's transparent and it's open and it's pure. And to me, that's the difference.
And to your point, there's no net vector, because you can go out there and your message could be randomized trials for boosters. You'll gain some followers. Your message could also be boost those kiddos with no data at all. And those people can also be popular, and the market is sort of sorting it out. Tracy, I'm curious. You have been the victim of a lot of slander. And I personally think you actually don't have conflicts, but I wonder if you might talk about how you think about it.
Oh, so that's an interesting question. So, I mean, I think that, I was just considering this because a lot of people have said like that I one of the things that I haven't done wrong is I haven't talked enough about the benefits of vaccines, and I would say that in our last episode I brought up the original clinical trial data and the regression discontinuity showing benefits of the vaccines in the older population and people who haven't already been infected, and I've been talking about I actually think it's important in our online presence to sort of like kind of show both sides of the discussion, and been talking about how there's this inverse correlation with excess all-cause mortality and the vaccination rate of
good point, right? Country. So that you reject the all-cause mortality argument from Europe,
because it's easy to sort of get fixated on a point that you want to prove, and then you kind of come off as biased. And so I do think it's important if we're like I guess public figures representing medicine and healthcare, that we kind of show that we're actually trying not to take sides. But I think in terms of conflicts, one of the biggest things that we've seen in that wasn't the pharmaceutical conflict was more like researchers who have previously pushed for a certain policy who then kind of are hopeful to see that result in their own research to back up what they've done in the past. And I think we saw that, with probably the Boston masking study.
And just to tell listeners that one of the authors has a change.org petition that says mask dem kids, and then they have a paper that says, and that really works well.
Right. And so that, like, also the Duke researchers funded by NIH, like basically publishing, studies showing that masks work without control groups. And, that I think it's been an issue that people have been conflicted in that way. But
let me push you on it. Okay. Barack Obama was pro-choice. Okay. And when Barack Obama talks about why he's pro-choice, he cites evidence that, it's safer for women, et cetera. Is that the same kind of conflict, or is what you're talking about different than that? And because do we think of Barack Obama's conflicted?
Yeah, right. So he's citing evidence to support what he's saying, whereas I'm actually talking about researchers, actually doing a study to support what they've done in the past a little bit. So this is actually about their publication.
Let's say he actually conducts a study, and then his study is going to be the benefits of Roe v. Wade.
Right. So then that's the importance of what is the study design? What are the confounders like? And then and also are the data available? And I wanted publicly available for reanalysis. And I actually wanted to get to that point because I thought this tied in nicely with what we were talking about with the vaccines before. Is this issue of actually in Israel, the observational studies that have been done, especially with like the Khalid healthcare system.
No spoilers.
By Pfizer. No, I'm not. No spoilers.
Because we're working on a paper on this space. Okay.
Publicly available. Okay, so they're sponsored by Pfizer, but not making their data publicly available. And I think that just, that really magnifies the risks of the conflict of interest if researchers can't go in and then reanalyze the data. And so I do think that that's kind of like a bare minimum of what we should be requiring of when the farm. And I'll just point out one more thing, which is that in terms of randomized trials, I just looked at this review yesterday published in BMJ that showed that 99% of all the randomized trials during the COVID pandemic were on pharmaceutical products and not on non-pharmaceutical interventions. And so that's another issue, is so much of the money is just coming from the pharmaceutical industry, and it dominates all of our focus in research. So we actually don't get answers to questions on, many other types of mitigations that we're looking at, or things that, other things that people are recommending besides drugs.
That's super well put, and an important point. And I guess, I just want to push it one more time, then I'll give it to Adam. But I do think there are many carcinogens. Obesity might be a carcinogen, and schistosomiasis is a carcinogen, and maybe alcohol is a carcinogen. But the one carcinogen I know, odds ratio 20, is smoking. So there'll be other carcinogens. There's the one. And for me, financial conflict is a smoking of bias. 200 studies show it has an odds ratio. We showed it had an odds ratio 30 in a paper that I did with Allison Haslam. Intellectual bias for me is slippery, because if you start to think of a study, how do you define it, and how do you study it, and how do you find the odds ratio? I think it's not so easy. And I'm kind of on John's page in terms of it's really just sort of a plethora of ideas and people going in their own space. All right, Adam, your thoughts? Are you satisfied that we're good people and they're bad people?
I'm not totally satisfied. I think you're absolutely right about financial conflict of interest. There's no question we need to consider that. But we also have to admit that everybody is always going to be working on and commenting on things that they feel strongly about. And it's important for those people to be honest with themselves, intellectually honest, honest in the way that they design studies, honest in how transparent they are about study design. So we can assess, look, is this someone kind of on the up and up because they're interested in this, they're studying it, they want an answer, or because they're so intellectually conflicted that they couldn't imagine a different finding, that they couldn't imagine that masks don't work in the Boston public school system, right? And we need to be able to think about that for everybody we interact with.
Yeah, that's well put. All right, everyone gets a closing thought. Start with you, Marty, then John, then Tracy, then Adam, then we're out. Marty, closing thoughts?
I'm still thinking about the toilet cover and how that could reduce aerosolized transmission.
Somebody said that on Twitter. Somebody did say that. Siren emoji, put that lid down, whoosh.
Well, it's a profound hypothesis, so I'm interested. Now, I don't know if Dr. Fauci is on this editorial Zoom call here. If I don't see him, you may want to pass this on to him.
You mean the science himself? You're saying the science? Dr. Fauci is the science, just so you know.
Many have claimed he is. So Tracy brings up a good point. Almost all the money for research comes from the pharma companies themselves. Isn't this an ideal role for government to say, we're going to fund studies where pharma is not funding studies? We're going to fund studies where there's a scientific unknown, where there's a public health void of knowledge. I mean, they've got $45 billion a year to spend. And isn't this an opportunity for them to fund?
That's why they funded the Wuhan lab. I mean, no, just kidding. No, I don't.
DOD also funded.
Yeah, okay. But your point is that Fauci should have funded NPI randomized controlled trials. He's a $6 billion budget. He could have done it. He was the man to do it.
I mean, when we think about, I don't know how your research teams work, but we sit down as a research team at Johns Hopkins and decide, what can we study? We also think about where can we get funding for studies. Now, we have some generic money from donors that, it's not non-directed, non-specified, non-directed money that we can dip into, but we've got to think about where can we get funding. So the only way you can get funding for a study from industry is if they perceive that it could advance their financial interests. What about studies that need to be done that may not advance financial interests or challenge deeply held assumptions about those companies' products? That's where the NIH should be stepping in.
John, closing thoughts?
Yeah, regarding the first topic, I just think that the lesson is be nuanced, embrace uncertainty, treat people as if they can understand complex issues. And on a matter of funding science and conflict of interest, I just think we underestimate the conflicts and the confluence of interest that it requires to get funding, and the fact that most of our science is funded by industry. And I couldn't agree more with Marty that we need sort of upstream policy solutions to fund science that's important, but may not be in those confluences of interest with profit-driven enterprises.
Tracy?
Yeah, and I would actually just add to that thought that, I don't know if it's the right paradigm in the US for all of the funding or most of the funding to be coming from the NIH. And I would just give my own experience from Denmark, raising money to do my PhD. I got most of my funding actually through generic foundations and grants, where you could basically use the money to do the study that you set out to do, but without, there was no sort of financial conflict of interest with it. They weren't looking for specific results. And I was actually looking at the funders of the Qatar vaccine studies, and it looked like that was more generic funding. And I was interested, that they actually looked at that. They were really the first ones, or one of the first ones, to look at the natural immunity question, and also look at the waning of the vaccine effect, over time, sort of gave us the most transparent results. Compare that with Israel, where they really just looked at a snapshot of time and potentially confounded results. But I think the issue with giving so much centralizing all of the research funding, or not all of it, but so much of it with the NIH, is sort of what we've seen with the pandemic, that people sort of feel trapped in that they have to publicly say and do certain things to continue to be funded by the NIH. And I think that's ended up being a conflict, or sort of has, prevented, I guess, our scientific understanding from progressing as quickly as it could have, because people feel like there are things they can and can't say. And so I feel like a solution moving forward is going to be having more of those generic donor type of grants for medical research, where it doesn't necessarily come from the NIH and centralized funding, or from the pharmaceutical industry.
I guess I'll just to give Adam the last thought, but I'll just add that there are some people who actually say that NIH, the way the funding should be is modified lottery, have very low criteria to make sure people with like severe typos, we throw them out, and then just literally randomly pick people because the current infrastructure is so bad, it's no better than randomness. Adam, closing thoughts on this issue?
Vinay, you and I wrote in Ending Medical Reversal, and like everything else in that book, it's been ignored.
I was going to say, that's the big difference in fun. We're not making that much money from it. Okay, yeah.
Well, we wrote about in that, we proposed a model that, pharma would sort of give the money for the studies that need to be done of their drugs and other drugs, right, to a, third-party funder. And I think we need to move to that because, listen, as John said, pharma does a whole lot of good. We have a lot of great drugs, vaccines, devices, so on and so forth. But we need to have those evaluated in a disinterested way. And I think the only way is to pull money away from them so somebody else is designing these studies, doing these studies, analyzing these studies, and amazingly writing them up.
That's well put. Thank you all for doing this. It's been a pleasure.